Thank you for that introduction, and I did want to talk a little bit about urothelial cancer in Lynch syndrome. This is something that has sparked a lot of interest at our institution, and you know, when you think about Lynch syndrome, it does tend to be one of the generate a little bit less conversation as compared to the kind of more heavy hitters like colon and endometrial cancer. But we do know that the incidence of urothelial cancer is increased in Lynch syndrome. As we've alluded to before, these are some tumor screening recommendations. The NCCN is the National Comprehensive Cancer Network, and this is one of our guiding bodies for management of both cancer patients, patients who have cancer, and patients who are at increased risk due to genetic changes such as Lynch syndrome patients. And so they issue recommendations every year. Multiple people from our group actually do sit on this committee, which is a national committee of coalition of cancer centers across the United States. So in terms of thinking about all of the cancers that are screened all the cancers that are diagnosed in the United States, you may have heard that there is a movement towards what we call universal screening for Lynch syndrome in colon cancer and in endometrial cancer. And that basically consists of doing mismatch repair, immunohistochemistry, or microsatellite instability testing, very specific kinds of tests that point towards but are not diagnostic of Lynch syndrome, on all colon cancers and all uterine cancers. What this slide highlights is that we're starting to think about actually doing those special laboratory tests on other types of cancers that are associated with Lynch syndrome as well, including small bowel and pertinent to this conversation, bladder and urothelial cancers, as well as pancreas, biliary, and brain, and things like that. It's not quite as, that type of screening in the general population to help us actually look for Lynch syndrome in people who have those cancers is not as well established as it is for colorectal and endometrial, but you can see that this is on the horizon and that it's moving in that direction. So what is the risk of urothelial cancer in Lynch syndrome patients? And we've already talked about this a little bit in some of the previous presentations, but I'm going to break this down by two different areas. One is the urothelial cancer that occurs in the kidney itself, or in what we call the renal pelvis. And we can see that the risk rates are different depending on what kind of genetic mutation associated with Lynch syndrome is present. And we can also say that the age of presentation is different based on which gene is altered as well. For example, we can also see here that MSH2 or alterations in EpCAM do seem to cause an average age of presentation of a renal pelvis cancer at an earlier age, in the mid to late 50s, and the cumulative risk does appear to be significantly higher in this group, suggesting that those with MSH2 mutations may have as high as a 1 in 4 chance of developing a urothelial renal pelvis cancer in their lifetime up to age 80. It's a little bit hard to compare these numbers to the general population because renal pelvis cancers are not the typical kind of kidney cancers that you hear about when people are talking about kidney cancer. Renal pelvis cancers are actually pretty rare in the general population, and so the lifetime risk of a renal pelvis cancer in the general population is unknown. So clearly all of these risks in this column are higher than that in the general population, but how much higher is hard to really quantify at this time. Similarly, bladder cancer, again, part of the urinary tract, but a little bit further down, is a more common cancer. And it's something that we do see fairly frequently in the general population. About 2.5% of the average individual in the population has about a 2.5% risk. But we can see that those risks do appear to be increased for people who have MLH1, MSH2, and MSH6 mutations. They don't really appear to be increased in those that have PMS2 mutations. That seems to be similar to the general population risk. And again, we also do see that the risks, for reasons that we don't really understand, seem to be higher with those that have MSH2 mutations, and that they do seem to occur at an earlier age. The other thing that's important to remember, and this is data from a paper that came out in 2018, is, again, this was looking at a group of Lynch population patients who did have urothelial cancers, and you can see here that of that group,
the majority of those patients who had urothelial cancers who had Lynch syndrome had mutations in MSH2. So almost 3/4 of them did have an MSH2 mutation. The other thing that's kind of interesting from a pathologic standpoint is, as you may be aware, tumors that are associated with Lynch syndrome tend to be what we call microsatellite unstable or microsatellite high. And we can see here that most of these tumors were actually microsatellite stable. So that's kind of an interesting coincidence, and we don't necessarily know what to do with that because we know that this was in fact a Lynch population. The other thing that's important to be aware of is, generally when you're getting your counseling about urothelial cancer as a Lynch patient, you talk about the renal pelvis and the ureter because those are the less common cancers in the general population that appear to be more common in a Lynch population. But we can still see here that bladder cancer is very common in the Lynch population. It's just the difference between that incidence and the frequency in the general population is not as great. So bladder cancer is still something that as a Lynch patient you do definitely need to pay attention to as well. These two graphs here are looking at a couple of different things. These are what we call survival curves for this slide on the left. And at the top, you can see that 1.0, everyone is alive. But for people who have urothelial cancers, this looks at whether or not people who have Lynch syndrome and have urothelial cancers live longer or live shorter than individuals who have what we call sporadic urothelial cancers or urothelial cancers not associated with Lynch syndrome. And this demonstrates, although it's a little hard maybe to interpret, but you can see that these lines kind of cross each other in a couple of different places and are generally in the same place. And this suggests that survival with a urothelial cancer due to Lynch syndrome is similar to survival for someone who has a urothelial cancer who does not have Lynch syndrome. On the right here, we have basically the distribution of age at diagnosis of urothelial cancers in the Lynch syndrome population, which is the blue, versus the general population, which is the red. And what we're really looking at here is the peak. And we see a peak in the blue bars for the Lynch syndrome population around the age of the late 50s to 60s, with a few outliers here. And we can see that the peak really is more in the 70s and going towards 80 for the red bars in the general population. So this again demonstrates the principle that urothelial cancers do tend to be diagnosed at earlier ages in Lynch syndrome patients than in the general population. So how do we screen for urothelial cancers in Lynch patients? And this is kind of a loaded question. If we go back to our guidelines group, the NCCN, they don't give extremely clear guidance, and that's partially because we don't have the kind of evidence from studies that can tell us what the right answer is for this. This is a prevention strategy from MSH2 because it is the highest prevalence, as I mentioned before. But you can see here that there's no clear evidence to support surveillance. However, the absence of evidence doesn't necessarily mean the absence of benefit of the surveillance, and certainly doing things like urinalysis on a regular basis, sometimes urine cytology could be considered as relatively low cost and low and non-invasive screening methods that can be easily done. And again, we usually consider starting those around the early 30s for that. I did want to put in a little bit of information about the symptoms of urothelial cancer so that you as patients will know what kind of things you might need to look at or what might be a cause for concern or further investigation. So as you might imagine, if blood is seen on a persistent basis in the urine, that is something that needs to get evaluated, as does a pain or burning sensation during urination. Now, of course, some of these symptoms could be due to something as simple as a urinary tract infection. But again, when these are in place, or particularly if they're persistent, this really does need to be checked out by your physician. Weak urine flow can sometimes be a symptom as well, suggesting that maybe there's a block or something that's preventing that flow from occurring as well as it might. What we call increased urgency to urinate even when the bladder is not full. Urination more often can sometimes be a symptom of having a either a urinary tract infection or a urothelial cancer. Sometimes if the other kind of non-specific symptoms, especially in conjunction with some of the symptoms that I've mentioned before, can be clues as well, including low back or pelvic pain, new onset of fatigue, swelling in the feet, or unexplained weight loss. And certainly, particularly for those last four things, those always need to be checked out by a physician should those occur, regardless of one's Lynch syndrome status. It's also important to realize that Lynch syndrome is not the only thing that causes urothelial cancer, and that smoking is a major risk factor for these as well. So this is, again, a further incentive for patients who are Lynch syndrome, who do have Lynch syndrome, to think about stopping smoking or not taking it up, because, again, that can compound their risk as well for urothelial cancers. One of the things that is discussed a lot for people who have more advanced cancers is the use of immunotherapy, or specifically PD-1 inhibitors. For people who have a cancer that's spread to the lymph nodes or to a more distant site, immunotherapies have been found to be very helpful for Lynch syndrome patients who have colorectal cancers and other microsatellite unstable or microsatellite high tumors. So, in terms of immunotherapy for urothelial cancers, just to give you kind of a setting in some terms of some of the data here, pembrolizumab, which is an immunotherapy drug, has been studied in non-colon cancers that are high for microsatellite instability and have about a 71% response rate. That's what that 71 ORR means. And that is really a very good response rate in the world of advanced cancer. So that means that the tumor had some shrinkage. It may not have gone away entirely, but it did appear to be favorably impacted by the drug. So when we think about, in light of that, the National Comprehensive Cancer Institute, when they make their recommendations for how we treat bladder and urothelial cancers, we do think about immunotherapy as one of our options, one of the tools in our tool bag, if you will, for treating people who have advanced urothelial cancers that can't be managed by surgery. If a urothelial cancer is limited to the kidney or part of the urinary tract that can be removed safely surgically, then surgery remains the first line. But again, for a disease that's not really amenable to surgery, we do think about immunotherapy in several different contexts. This gets a little technical, and I'm not going to go into all of the details there, but immunotherapy certainly is used on a regular basis in urothelial cancers, both for Lynch patients and for patients who do not have Lynch syndrome. And so I'm going to go ahead and stop there right now, but I thank you for your attention, and I'd be happy to answer any questions as best as I can. Thanks.